Okay, we're back for part three. That's thromboembolic events. And thankfully, these are rare, but they do happen. We actually have had two ladies on Sunday up on the postpartum unit where I work. One had a DVT and one had a PE. I don't know why maybe she came down from the ICU, but they were both being managed on heparin drips. And because this can be life threatening, we want to make sure our patients know about it before they go home from the hospital. And we want to do everything we can to prevent it. So, deep vein thrombosis, risk factors, obesity, for the same reason that it puts the general medical population at risk. It impairs venous flow. Sedentary habits after delivery. I I don't know how many times I can say walk, 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 walk after you deliver, especially if it's a C-section. And if it hurts, take pain meds, but you need to walk. A past medical history is a strong predictor of a future DVT, and family history of DVT or abnormal blood clotting is another risk factor. Cesarean birth, positioning in stirrups for long periods. We don't usually use stirrups that much for vaginal delivery anymore. You do see it sometimes with complicated repairs, or if we have to do a DNC, or like when we did the evacuation of the hematoma. Um, we have to position people in stirrups. So you want to watch the periods of time and make sure the person has SCDs on connected to a pump that's turned on while she's in those stirrups to keep the blood flowing back to the heart. And anybody who is planning to travel after delivery should probably put that off. If they're driving, they need to take rest breaks. Airplane travel is probably not a great idea. But those are some risk factors. So I have a picture here of what a DVT looks like. And you can see this leg is a normal size, maybe not real well developed musculature, but it's a normal size leg. It's a normal collar leg. Over here, we have redness, heat, and swelling. And presumably this person also has pain. It is a unilateral event. It only happens on one side. In pregnant and postpartum women, I do not know why, but it's usually the left side. Homan sign used to be like the classic postpartum part of your bubble heat check. It's not a great indicator. It probably only predicts about or diagnoses. It's positive in about a third of DVT cases. Some people have said that there's a chance that you could dislodge the clot while doing Homan sign because you're sharply dorsiflexing the foot. So Homan sign is really not a good indicator. But if you see a leg that looks like that, feel gently with the back of your hand without massaging the back of the leg. You don't want to press hard because if there is a clot, you don't want to send it into the circulation. We may see a low-grade fever because of the generalized inflammation, and sometimes that progresses to a higher temperature. A palpable cord is when you have that clot affecting a vein, you can sometimes palpate it. Just be careful that you're not palpating to the point where you're actually massaging the cord. Milk leg. Milk leg means that because there's spasm distal to where that clot is, the leg below the level of the clot gets white, cold, um, and sometimes the patient, it kind of looks like there's decreased circulation distal to the clot. It is diagnosed with Doppler studies, so they're going to send you for that. The provider will almost always ask you for a D-dimer, which is a blood test. And when that's elevated, it's very suspicious for DVT. So management, do not let this client get out of bed. If they walk, they could dislodge the clot. And that when a thrombus starts to move, it's called an embolus. And the place it's going to move to is the lung. So now we have a pulmonary embolus, which is life-threatening, and we don't want that. So don't do that. Don't massage the clot. At this point, you are going to get when you get your diagnosis, you're going to get orders most likely for weight-based heparin drip. And that is a topic really more for a med-surg course. We can play with it in class if you want to, but you're going to get a lot of lab values and you're going to get the patient's weight in kilograms and you're going to calculate the dose and you start there and you titrate. meaning that when you get labs back, you turn up, you turn down, or you turn off and restart. Um, but so that heparin drip is what's going to help, you know, prevent further clots from forming and, help that patient recover from the DVT. Eventually, we're going to convert to warfarin or Coumadin or maybe some other agent, but warfarin is the most common that I've seen still, even though there are some newer agents out there. And for that, we monitor PT and INR. INR should be 2 to 3 times the normal value. This should be review from MedSurg. Sometimes students will ask me, well, I see orders for heparin and Coumadin. Is that okay? Is that normal? Should I question that? And it's like, no, while you're waiting for Coumadin to get to that therapeutic level where the INR is 2 to 3 times normal, you're going to keep that heparin going because that's what's going to keep them from having a blood clot. And the patient should get education about anticoagulants. They should be taught to monitor for bleeding, bleeding gums, easy bruising, increased vaginal bleeding, cuts that don't heal. Like if they should be cautioned away from razors. If they must remove hair, use a depilatory cream like Nair, or use an electric shaver. But under no circumstances should they be doing anything that increases the risk of bleeding. They should be going for lab work. And if they're going home on Coumadin, they should also be taught about vitamin K. So Coumadin works by inhibiting vitamin K synthesis. If you change the amount of vitamin K, some women want those green leafy vegetables like spinach and broccoli. Well, they're really rich in vitamin K, and they can sort of negate all the good work you did with your Coumadin there. The antidote for warfarin, if a patient becomes hyper anticoagulated, so to speak, their INR is out of range, would be vitamin K. The antidote for heparin is protamine sulfate. That's an NCLEX thing. It's not specific to maternity. It's just what it is. Those are the things you would do if that person, if their prothrombin times were elevated, which means that it takes longer for their blood to clot. You're going to monitor for pulmonary embolus. As I said, a thrombus becomes an embolus when it starts to move, and the place it moves to is the lungs. So you're going to assess respiratory status frequently, and you're going to teach your patient to report any signs or symptoms, shortness of breath, coughing, feeling like they can't breathe, or severe anxiety, and better to check it out. And that's our DVT lecture.